Hello everyone, and welcome to the Employer Policies and Practices to Prevent Disability webinar with Dr. William Shaw. This webinar is part of our Effective Workplaces webinar series, and we're glad to have you here with us today. My name is Tanya, and I'll be moderating the webinar today. I'm the project manager with the Canadian Institute for the Relief of Pain and Disability, and this webinar is made possible through the support of the Community Grants Program through the BC government, as well as through donations and memberships to our organization. And as I mentioned, my name's Tanya, and I'll be managing doing the webinar and the Q&A session. And our speaker today is Dr. William Shaw. Dr. Shaw is the Senior Research Scientist with the Center for Disability Research at the Liberty Mutual Research Institute for Safety. Dr. Shaw's work focuses on improving return-to-work outcomes for work-related musculoskeletal conditions through the integration of clinical and workplace factors. Currently, he's investigating risk factors for delayed recovery from occupational low back pain and examining optimal supervisory practices for responding to workplace injuries. His other studies have focused on patient-provider communication of workplace concerns and the strategies that workers use to stay on the job while managing recurrent pain. We're really excited to have you with us today, Bill, so I'm going to hand it over to you now.
Thank you very much, Tanya, and thank you for everyone for joining us today and taking some time out of your afternoon or morning, depending on where you are. And I'd like to thank the CIRPD for hosting this webinar and allowing me to speak. So the title of my presentation is Employer Policies and Practices to Prevent Disability. And I will be talking mostly about research evidence around workplace factors and workplace interventions that have been shown to prevent disability. And I'll also be trying to focus on some of the gaps and disconnects that exist between the kind of information that's available to us today from research and maybe the kinds of information that employers are searching for to make decisions about their disability management practices. Just a few words about where I am working. I work at the Liberty Mutual Research Institute for Safety. It's located about 30 minutes outside of Boston, Massachusetts. It has a kind of a long legacy of doing work around workplace ergonomics and workplace injury prevention. And if you ever find yourself in the Boston area, please feel free to look us up. We have some interesting labs around biomechanics and work simulation and other topics. And my email address and the website address is shown here. Many of my comments today will be a product of a special conference that was hosted here at our institute in October of 2015. This conference was a little different than typical conferences. There were only 26 participants, and their names are listed here, and they were from all around the world. And what these researchers had in common was they had all published research looking at employer policies and practices, and maybe even more importantly, they actually had partnered with employers to try to collect this data and answer some important questions. So that's how they came to us, and this sort of structure of this conference was that the group was divided into subgroups, and each one was assigned to one of these categories that you see listed on the right here, and asked to actually produce a draft manuscript and then further develop that after the conference into a full-fledged journal article, and those can actually be found in a special issue of the Journal of Occupational Rehabilitation that was published in December of 2016. So if you go to Springer Link, you should be able to find those, and they're all open access. So if you have further questions about this topic, that's a good place to search. And maybe one more thing to mention about this conference was that the researchers were given two pieces of information to help them. One was just to access scientific literature in the normal way that they're accustomed to, and the other was that we actually gave them about 30 documents that were what we consider to be gray literature publications. So these were different sorts of best practice manuals that had been designed by business for business to help in disability management decision making. And we looked at sort of the contrast between scientific research evidence and the kind of evidence that might be landing on a human resources director's desk. So have a technical problem here. Okay. Okay, Tanya, am I back on?
Yep, everything looks good.
All right, my PowerPoint stopped working for some reason. All right. So one of the questions that researchers at this conference kept asking throughout the conference was, why should employers care about disability? And I know that sounds like a provocative question, but it was something they talked about a lot. And one of the groups was actually tasked with looking at the business literature to see what kinds of information was being provided to employers to really try to encourage them to provide better disability management practices. And one of those issues was legal compliance, and this was by far the most important issue in this business literature. And so employers really want to make sure that they're being compliant with regulations, whether they're in the US or Canada, it's really, or anywhere else. It's really important to not get in trouble this way. Another issue was cost containment. So reducing workers' compensation costs, reducing healthcare expenses. So in the U.S., a lot of employers are paying a huge share of healthcare costs, and when people are out of work, they're usually incurring more healthcare costs. So cost containment is an issue. For some employers, just having good disability management practices is a part of having good, sound business practices in general. So having fair accounting, keeping good records, and that sort of thing is another reason to track disability costs and work absences more carefully. And then the last issue that was brought up in the business literature was this positive organizational culture, that some employers feel that managing disability is really a part of their culture and something they want to do to really communicate to their workforce that they have an inclusionary workforce and that they do try to spend effort to try to address the problems of individual workers. And the idea behind this is that it provides a competitive advantage both in terms of profitability, attracting new talent, and keeping a happy workforce. Now for researchers, there are a lot of other issues too that should suggest that employers should be very interested in preventing disability, and these are really demographic and health trends that we have, and one of them is well known to us all, which is an aging workforce. So this is a slide from the Cornell University Employment and Disability Institute showing that in the US by 2030, 1 in 4 workers will be over the age 55. So this is something that employers will see more of. A couple more statistics that are important to keep as context. There's a growing prevalence of obesity, particularly during the working age years. The USA is by far the champion of this problem, but most other countries are also following a trajectory, an increase over the recent decades. And this has just begun to trail off in the US, fortunately. In addition to obesity, there's really a growing prevalence of chronic health conditions among the U.S. workforce and elsewhere. There's, in one survey that's shown here on the left, only about half of workers reported no chronic conditions, and about 10% reported 3 or more. So the health of the workforce is declining, and in this Gallup poll, it was even concluded that that 86% of full-time workers were either above normal weight or had at least one chronic health condition. So employers are going to continue to see more health problems in the workers that they hire. And in the U.S., this has just begun to get some airtime with the Washington Post and other sorts of popular press, but if you look at the rate with which people apply for full-time permanent disability benefits through the Social Security Administration in the U.S., this is really escalating at a very quick rate as baby boomers enter the 50s and 60s. And this cannot be replaced by the number of people that are entering the workforce, which is the blue line on this chart. So this is sort of an unsustainable problem from a financial and societal standpoint for us. Another thing that's interesting to note is that the reasons that people actually file for disability have changed. So there's a lot of information on this slide, but if you look on the left-hand side, this is in 1961. Most of the causes of disability were heart attacks and stroke and neurological disorders and wartime injuries. And that's really changed for a number of reasons. We probably treat those conditions better now. We maybe diagnose these conditions earlier, but now the conditions that really lead people to apply for permanent disability are back pain and musculoskeletal conditions and mental health problems. And so it's been said that these are the kinds of problems where employers really could have a really major impact in trying to provide job accommodations to help workers stay on the job with these kinds of creeping and slow onset problems. So what does disability management mean in the employment setting? Employers deal with disability issues in a number of different categories. Return to work is the thing that's been studied most in research. Recently there's been more effort to look at stay at work, which is trying to keep people on the job before they have work absence. Also dealing with the kinds of work limitations that might occur due to chronic health conditions and this issue of presenteeism. And then other issues are hiring and accommodating disabled workers, administering sickness and disability leave programs, and actually re-employing people after they've been through a vocational rehabilitation program if they have not been able to keep their usual job. So from an employer standpoint, there are many different silos in which the disability may become an issue. But of course, employers are not the only ones that are tasked with trying to prevent disability. This is a model that's sometimes called the ARENA model. It's an overall societal context of work disability that was developed by Patrick Loisel and his colleagues a few years ago. And you can see that the workplace system is shown in blue here on the top, but also there's the healthcare system and its ability to rehabilitate workers and to communicate with employers on work disability. There's personal issues of coping and dealing with pain and other symptoms. And then on the far right in the yellow is the legislative and insurance system as well. So there's many different factors that influence disability, and the employer is just one of those. If you look at research on employer disability management practices, most of it really comes from the perspective of workers. So workers are recruited through clinics or through the community. They may have experiencing a health problem, and the kind of information they provide about their employer is really where we know the most about employer policies and practices. We also have some research where we ask clinicians who work in this rehabilitation area to comment on the kinds of things they see in the workplace. And lastly, there's the employer perspective. And in this conference that we held in 2015, we were particularly interested in how can we encourage this kind of research to occur. How can we partner with employers to try to understand this problem from their perspective and to have more of a balance in the research that's available to employers and to others as well. So I'm going to talk now about some of the workplace factors that have been mentioned in the literature and that have seemed to be supported as risk factors for prolonged disability. And it's important to note that employer policies and practices have really been assessed at this individual level where we have information about things that employers do for a particular person. And then there's also organizational level influences as well. So things that an employer puts in place so that disability might be prevented on more of an organizational sense. There have been enough of these studies that have been done where people have been asked many questions about their workplace, and then they've been followed for a period of time measuring various disability outcomes. And we have systematic reviews of those factors as well. So of these 5 systematic reviews that were published between 2001 and 2005, you can see that there were as many as 68 studies that they tried to incorporate in their review. And the general conclusion of all of these reviews, and again this is information taken from the perspective of the worker, is that occupational factors, both physical and psychological, impact return to work rates and other disability outcome measures. So I'm just going to go through the 7 types of workplace factors that are most evident from that literature, and this was one of the things that one of our groups at this conference tried to distill down to some more easily recognizable categories. So one of the areas that's been very well documented in the literature is the physical aspects of job demands, and it's primarily heavy physical demands or fear of re-injuring yourself doing something that initially had caused an injury. What's interesting about heavy physical demands is this is really information that comes directly from a worker. Is much more predictive of outcomes than information that might be collected if I were to go out and just take some measurements with a force meter and try to measure actual workload requirements. And fear of re-injury is important because it may be that workers have very particular problems that they see with their job. And if we don't ask those kinds of questions, then we don't really understand what it is that we need to try to modify or deal with in terms of coordinating return to work. While physical aspects of the job are fairly straightforward for employers to try to deal with, these psychosocial aspects of the job, things like job stress and job dissatisfaction, are much more difficult to deal with. But certainly when we have a case of a worker who feels that their work is very stressful and that it's not a job they particularly like, that is certainly kind of a red flag that this case should deserve a little more attention. And so even though these things are difficult for employers to deal directly, it certainly is an indicator of trying to identify this case as potentially high risk and needing some extra help. Other factors at the workplace that have been shown to result in longer-term disability are things like low social support and the inability to modify work. So if you're new on the job and you don't really know people and don't know how to ask for help, or if you work in a solitary space where finding assistance from a coworker might be difficult, that's a risk factor. Or if you're in a type of job where it is either you feel the company would not be willing to modify your work, or if it's the type of job where just modifying the work is very difficult. So in the case of a school bus driver, there are issues of public safety. There might be limitations in terms of really what can be done. So those are additional risk factors. And the last one is just this idea that workers who feel that really anything they try to work out with their employer doesn't work out well, that's a very strong predictor of poor outcomes for return to work and other disability outcomes. So on these kind of cases where someone feels that their employer is not playing fairly with them, this is definitely an upstream battle. Just to give you a sort of a more specific research example of these, a few years ago we did a series of focus groups with workers who were out of work, and this was all cases of low back pain, and we asked them, what is it about your workplace, or what is it about your work that you're concerned about in terms of resuming your job? And if you see these kinds of things over here on the left, the physical limitations, these are the kind of things we're usually accustomed to dealing with in terms of job modification. So people are concerned about their ability to sit for a long time, stand for a long time, push and pull and carry things. And those are the kinds of things we deal okay with in terms of medical restrictions. But a lot of their concerns had more to do with role performance. So if I'm not 100%, is that going to reflect negatively on me in terms of evaluations in the future? Am I going to have trouble keeping up with the speed or quantity or quality of my work? Is it going to affect my relationships with my supervisor and coworkers? Am I going to be able to tolerate pain while I'm at the work? So these are really different than just trying to overcome physical limitations. And lastly, workers talked a lot about, if I return to work, bad things could happen. I might lose my job. I might be embarrassed by my colleagues, and I might just think more poorly of myself to come back to work when I'm not 100%. So these are the kinds of things. So as employers adopt policies and practices, they really need to consider not just physical limitations, but some of these other more organizational aspects that might be of great concern. This is a little bit of a complicated slide, but one of the other things that we tasked our conference attendees with was to look at some differences in the kinds of workplace factors that are evident from the scientific literature and those that are really in the business literature. And what they generally found was that scientific research tended to focus on the individual's experience in the workplace, whereas the business literature focused more on organizational aspects. So what kinds of things happen in the workplace that can really make these workplace factors lead to poor disability outcomes. One of the things that was pointed out at the conference was that a lot of this has to do with communication, and in particular that a lot of communication around return to work is really a very one-way communication. So if you take the example of an injured worker, the worker goes and sees a provider, the provider evaluates their condition and maybe makes a recommendation for medical restrictions to a personnel manager or a disability case manager, and then that person calls the supervisor and says the worker will be back on Monday and here's what you need to do to accommodate them. That person meets with the worker when they come back on Monday morning. But if the worker comes back and begins to have some more pain or more symptoms, really their only recourse is to now go back to the healthcare provider. So they will frequently say, well, I'm having problems, I'm not sure what to do. So if adequate follow-up and communication is in place to allow the worker to talk to the employer about problems they're having, they can really only go back to the provider. So there's a lot of one-way communication. You'd like to get all these people in the same room, but that's sometimes very difficult. Another limitation or another problem in the workforce is the kind of over-reliance on a simple job matching process, which works for many cases but not for all. So we'd like to think that if we have the job description on the left side of our desk and we have the medical restrictions on the right-hand side, it should just sort of naturally lead to the kinds of job modifications that we need. But it's often much more simple than that. This really presumes that workers have all the information about the workplace they need to come up with some really clever and perfect job modification recommendations. It also assumes that job restrictions are sort of easily applied in most workplaces and that worker input's really unnecessary. And the researchers at our conference came to deal with that problem, came up with this idea, which is that on more difficult and complex cases, or maybe cases where there's some adversarial relationships already, job modification needs to follow a bottom-up process rather than a top-down process. So if you look on the left-hand side where it says top-down process, this is what happens typically on a disability case. So a doctor makes a diagnosis and assesses function and makes a recommendation for modified duty that goes to the employer, and then the worker can accept the offer of modified duty. But on difficult cases, what the researchers thought might be more effective is just the opposite. Have the worker and the supervisor meet together and talk about the worries that the worker has, the kinds of job modifications the supervisors might be able to put in place, and then talk to the HR department about whether or not that could be possible and meets the policies of the company, and then bring that information back to the physician or healthcare provider and ask them to provide medical clearance to allow that to happen. So kind of a different sort of process that really starts with the worker and trying to understand the problems they're facing and ending with the doctor instead of the other way around. Another point that was brought up by the researchers and probably another source of disconnect for employers is that a lot of the research is really shifting towards looking at more psychosocial factors than biomedical or biomechanical ones. And this is a sort of a difficult thing for employers to deal with in terms of return to work. So in future research, we need to find a way to adopt a language that is still addressing some of the things that we think are important risk factors, but in a language that employers might be able to embrace more readily. So I'm going to give you an example now. We're going to go from workplace factors to talking more specifically about intervention. One study that was done a while back, but was really a bellwether study in terms of spawning a lot of other studies to try to replicate this, was a study that was done by Patrick Loisel, and it was is now referred to as the Sherbrooke model for back pain. And it's important because it was the first study to really show that if you take a workplace rehabilitation intervention and you add some sort of workplace outreach component to it, it really does improve outcomes. So in this study, there were some groups of workers who got usual medical care. There were some that got an additional clinical intervention that involved education about back pain and more of the things that we think of in terms of multidisciplinary rehabilitation. And then there were groups that got that as well as a workplace intervention. This was an intervention that involved elements of participatory ergonomics to understand the problem from the worker's point of view. It involved some cooperation with the employer through an employee manager group, and it involved individual return to work planning meetings so that job modifications could be arranged more carefully. And what that study showed, if you look at the blue bars here, there's not a lot of difference at 12 months between the outcomes. There's a little bit better outcomes in the research groups than the intervention groups versus the usual care group. But what you really see is a very pronounced benefit when you go out as far as 6 years. So the clinical plus occupational group on the far right, you can see is doing pretty well in terms of lost days on full benefits, but the usual care group is really experiencing a lot of benefits. So this study really has become a kind of a direction that research has headed to try to understand how we can add workplace interventions to clinical care. Since that study came out, there have been a number, at least a dozen other studies that have tried to replicate this, and we actually have enough studies now that we can do meta-analyses and fancy systematic reviews. This is the results of a Cochrane review that was done very recently. And just to show you, if you look to the right, this is called a forest plot, and the diamonds represent the intervention benefits of the intervention. If these were on the left-hand side of that line, it would mean that there was actually a disadvantage of the intervention. But they're on the right, which means that there's an advantage. And you can see that they're right around 2. So actually, when you add a workplace intervention to clinical rehabilitation programs, it tends to increase the likelihood of return to work by about 2. So the news is really good in this area. And what are some of the common elements of the interventions that kind of fall into this category from this review? They tend to be participatory ergonomics, often involve problem-solving processes to try to ease communication. Oftentimes the focus is on a better job accommodation process, trying to communicate with the doctor and loop them into the workplace issues realm, to try to focus more on the worker and have them be more a part of trying to generate solutions, recognizing that it's an iterative and continuous process, just like this problem-solving wheel here shows that you can go round and round if you need to, but all these interventions have tended to be not all that time-intensive and not very expensive either. Another thing that our research conference attendees really wanted to emphasize in their papers was that job accommodation really works. You know, as best we can do in terms of researching this, we really see there are tremendous benefits to a worker knowing that an employer is going to try their best to try to modify their work to deal with any symptoms or limitations that they have. And there's evidence that this doubles the likelihood of return to work. It reduces disability costs by half. And one perhaps negative point is that only about 2/3 of recommended accommodations are actually implemented. So we still have some more work to do in terms of how we get employers to coordinate and implement job modifications. So I'm going to shift a little bit. Most of what I've been talking about so far has dealing with what we can do for an individual worker with an individual problem. And now I'm going to talk a little bit about kind of more at an organizational level, or what can an employer do. And this is an area where the research is a little more thin. One of the things that our research conference attendees wanted to say was that in a lot of the research that we have of employer policies, employers are kind of looked at as a single entity. So in a lot of the research papers, it'll say, well, the employer did this or the employer did that. But they wanted to recognize that there are really a lot of different levels within an employment setting. So it could be that the managers of a company are adopting certain policies and practices that are important. It could be that supervisors are having an impact in a certain way. It could even be that coworkers or the environment, immediate environment of the worker is important. Or it could be the worker themselves, the perceptions they have of their job that could be important. So understanding the organization from all these different levels is important as we go forward. One of the first studies that was done here in the U.S. that really got this kind of, that really increased the interest in organizational practices was this study that was done in the 1990s. And this study was, what they did was looked at 220 manufacturing firms in the state of Michigan, and this research team went out and interviewed people and collected a lot of data from all these workplaces. And then they went and looked at their workers' compensation data. So this is a state where workers' comp data by employer is freely available. And what they found were these sorts of things that they had measured in the employer settings were predictive of workers' compensation outcomes. So it's things like people-oriented culture and safety diligence, safety training, disability case monitoring. And you would think that this would have really taken off and yielded a lot more research, but unfortunately it's not. And there's still only kind of a handful of studies that have really tried to compare employers' practices and relate that to disability costs. There are a few, however, and one of the best reviews of this is a paper that was done by Renee Louise Franch at the Institute for Work and Health at the time. And what they came up with was these 7 principles for successful return to work, and this is information that's really helpful to use. And if you, the Institute for Work and Health has a lot of materials like this on their website if you want to consult that for more information. But it's the kinds of things we've been talking about, and demonstrate commitment to health and safety, a routine offer of modified work, supervisors trained and included in return to work planning, the designation of a return to work coordinator, and these are evidence-based practices for employers. One of the things we asked our research attendees to do was to look at the business literature and see whether these 7 things are actually evident from the business literature, and they actually found 12 things that from the business literature, and they noted the things shown in red here as potential research opportunities, things that could be done better by researchers that would help to inform employer practices. Number 4, one of those was to develop more practical tools and materials that employers could use to assist in return to work planning and job modification. Number 6, to look at the training and education of frontline supervisors, which I'll be talking a little bit more about in a second. Number 7, to talk about how information about disability practices is really messaged to the workforce in general. Focusing, and then number 10, focusing more on communication and studying those processes in research. And the last one, number 12, taking into account personal work and job characteristics. So finding ways that employers can handle cases differently depending on the types of problems and worker issues before them. Just to give you one example of a study that looked at organizational factors, this is one that I was involved in, looking at supervisor training, and it was just a 4-hour group training program that used participatory ergonomics and communication skills training to help them be more responsive to workers at the time of an injury. So some of the messaging to the supervisors through this training was to listen to worker concerns more carefully, to provide more support and reassurance, to meet with people privately and confidentially, to do some collaborative problem solving with them about particular barriers to return to work, to be more creative about suggesting job modifications and things like that. And we weren't able to get our technology together to show you and allow you to hear one of these videotape vignettes that was used in the training. But I'm going to just let it roll here for a second so you can at least see it. But one of the things that we did in this training program was we used a lot of videotape vignettes to illustrate some of the miscommunications or lack of communication that might exist between supervisors and workers. So in this particular video, it's a case of a harried supervisor who now has a worker walk in the door with an onset of back pain. And so we found that this was a really good medium for training supervisors because they felt uncomfortable talking about their own workers and specific situations that they'd had to deal with. But if you showed it to them in a video, it provided a great way for them to react to this that was reasonable for them and a little bit entertaining at times. So we've been able to take this training program to a number of different employers and measure things, different kinds of data in different places. One of them was to look at workers who were coming through an on-site clinic before and after the program was instituted, and that resulted in improvements from pre-training to post-training in some of these things. And particularly, if you look down the list towards the bottom, talk with me privately was one of the things we really focused on in the training program, and that really did improve. Also, the number of people reporting that their supervisor had blamed them or discouraged them from filing a workers' compensation claim also was reduced down to 0. So this was a really good outcome. Also, at a meatpacking plant where we did this training program, which is a place where, of course, there are many musculoskeletal hazards and work injuries. We were able to look at workers' compensation costs in terms of lost work time as we instituted the training program on a staggered basis through different departments, and that showed that about a 20 to 30% reduction in workers' compensation costs immediately, and actually resulted in much greater reductions over time. So this was information for this same employer over several years, and what it shows you is that so OSHA recordables in the U.S. are things that employers are mandated to report. Incidents in this case was the employer's collection of any information from the workforce about work injuries or potential work injuries. So they were really near miss kind of data. And what this shows is that after the program was instituted, the number of incident reporting went up, but the number of OSHA recordables went down, and the lost time went down and actually stayed down for a number of years. So that was a really good outcome. And just a few more slides. I'm winding up here. I just wanted to say that a couple things are happening around employer policies and practices that are beginning to permeate to the scientific literature. One is this idea of total worker health, which is an idea that's been trademarked by the National Institute for Occupational Safety and Health in the U.S., and it's an effort to try to bring together the siloed disability efforts around health and safety in the workforce into a single entity. So it's encouraging employers to try to bring these types of programs that they have in very different places all under one roof and have these people communicate, whether it's safety or disability. Another thing that was brought up by our research group is just how much the research shows that workers say that they were able to return to work because there were simple changes made that they already had available to them in terms of the job flexibility and leeway of their job. So these are not medical restrictions or official job accommodations. They were just ways in which their supervisor or their coworkers allowed them to work a little differently and still be equally productive. And sometimes these things we really don't take advantage of that. So one of the things I hope we can accomplish with research in the future is to take a better look at these things, not just medical restrictions, but the kinds of modifications that workers and their supervisors and their coworkers may be able to institute even on their own. I talk a lot to clinician groups about how you can begin talking about the workplace, and these are some of the questions that we try to encourage them to incorporate in any interaction they have with a worker with a health problem. What are your biggest concerns about returning to work? What job tasks will be most difficult for you? How can you vary or adjust your work to be more comfortable? How much help will you get from supervisors and coworkers, and how will you deal with future problems that might come up? One of the other observations from our conference attendees was that the workplace is really changing a lot, and research needs to change as well to address things like temporary work arrangements, small and medium-sized enterprises, which are almost not showing up at all in the scientific literature, telework and lone workers, and the kinds of things that are happening now with the advent of computers in the workplace. And they felt that really we need to start thinking about a workplace that looks like this instead of the one on the left. There is also a ray of hope in terms of dealing with some of the societal level issues in the U.S. around disability and some of the policy issues. The Office of Disability Employment Policy within the U.S. Department of Labor has recently launched a Stay at Work, Return to Work Policy Collaborative, where they've tried to produce a number of white papers and also set up a community of practice of both researchers and practitioners and employers to try to address some of the problems that exist that lead people to file for long-term disability after work absence. So in conclusion, I'd like to just say that that research and disability trends really support the need for employer participation in rehabilitation efforts, that we need to think not just about biomedical information, but also organizational and psychosocial information that may have a big bearing in terms of return to work outcomes, that participatory approaches involving workers and supervisors is really ideal, and that engaging employers can be really challenging, and it's actually been difficult for researchers to engage with employers, but these things have been able to show real impact. And thank you for your time, and with that I'll turn things back over to Tonya for questions.
Wonderful. Thank you very much, Bill. What a good presentation and really interesting research that you're doing. And very practical, which is also really nice to have the, like, even just the listing of the 12 best practices, you know, that came out of the literature is really, really helpful. Let's see, I would encourage everyone to go ahead and submit any questions you have related to the presentation. I don't see anything just yet. Someone is asking about the slides being available. They will be made available. I'll be posting a link on our website and I will email that out. So that will be available, yes. And let's see if we have any other questions. And someone else asking about the videos. Bill, you said the videos probably won't be available because they're proprietary. Is that correct?
Well, I guess these two that were in the slides, they'll have those in the slides.
Yes, but not with sound, correct? I mean, they won't because there won't be sound connected to them.
Yeah, let me see what I can do with you, Tanya. I could give you PowerPoint slides that have the videos embedded in them.
Okay.
For people to be able to download in addition to because it wouldn't show up in a PDF, but it would show up in the PowerPoint file.
In the PowerPoint slide, right. Yeah. Okay, we'll see if we can arrange to have those videos available for everyone. Someone was asking, is the U.S. white paper a collaboration with Canada?
I think they're referring to this ODEP series of publications, and it was not, but actually a lot of the people, now when I think about it, there was some representation of Canada, I think, on the panel, and that's because a lot of really good research and people are in Canada on this topic, and I think that it did include some people. So I think there was some Canadian DNA in this white paper for sure. And there was also a lot of interest in some of the things that have been done in the state of Washington, which is a little different from all the other U.S. states because it's a single-payer insurance system for workers' compensation, and they've been able to mandate that employers put certain policies and practices into place, and then they've partnered with the University of Washington to try to look at the impact of those changes in policy. So the answer is no, but I think it would certainly be relevant, and that there was some involvement of Canadians on the panel.
Okay, great. Someone asking, have there been any recent studies that looked at the business case for disability management with regards especially to specific dollar amounts?
Well, that's a really good question, and we certainly need more of that kind of research. And I think one of the reasons that we were really interested in hosting this conference is because we could see that the institute where we are, we're kind of in the middle between insurance customers and workers' compensation and the scientific world, and we see a lot of evidence that employers, they want that exact kind of evidence before they make any decisions. And the research wasn't always addressing that kind of question. So we really need research that looks at how an intervention or how a policy impacts workers in a positive way, but also that it impacts the bottom line of the employers as well. And we have, we were beginning to have examples of that, but it's difficult to set up a research design that allows you to do that. And I think actually there's been more resistance from at least large employers to partner with employers on these kinds of studies where they need to be able to share aggregate data on disability costs and things like that. So it's gotten a little more difficult. I'm not sure exactly why, but we certainly need more of that kind of research. And I think the kind of research that tries to address the interests of a number of stakeholders and not just employers would be best.
Very good. Are there initiatives to capture blinded employer data linked to interventions or evaluation guidelines for employers to improve data collection and analysis?
Yeah, so I think the question here is how can we get data from employers? And there are some examples of that. in the U.S., there's a Workers' Compensation Research Institute that has 8 or 10 of the largest insurers in the workers' compensation market share their claims data in sort of a blinded, de-identified fashion to try to look at trends in cost and trends in practices in healthcare use over time. But what's usually not included in those data sets is any information about the employer. So while they can make some conclusions about maybe large employers versus small employers, they really don't have any better information. So the real trick is to find a way to collect information about practices and then marry that with data on costs. And it's tricky to do. It's being done sort of at the federal level in a couple of ways. I know in our own institute, we have tried to do research where we have employers share data by departments, and we may be instituting some training or some policy change within departments to try to look at its effect on costs over time. And as long as the information from the employer is being done at just an aggregate level, like number of lost work days by department, they're usually willing to do that. You know, it's much more difficult to get individual level data because of confidentiality concerns and other things.
Right. Very good. Let's see. Are there any interventions on empowering workers in their recovery and return to work rather than having the disability management process being driven by medical factors?
Yeah, that's a really good question, and I can tell you that I've been a part of some studies where we have one in particular that comes to mind is a study with upper extremity disorders, and what we tried to do was take medical case managers and augment their services to involve a lot more face time with workers. So before they went and actually talked to the doctors, they would go talk to the workers for as many as like 2 or 3 hours. They would go to their home. They would try to find out, you know, what's your situation here? What are the kinds of problems you're encountering? What are some of the things that you're experiencing with your employer? And how can we address that? And they actually had a part of the intervention which was teaching workers problem-solving skills to help them address some of the barriers that they had. So it was really a large part of this intervention was putting workers in the driver's seat. And I think for any case that's, you know, even moderately complex or where there's maybe already some adversity in the claim or the case, in those cases it's really important to, you know, go to the worker, find out, well, what are the problems, what are the things that might go wrong that you're concerned about, and how can we address those more carefully. And we really don't do that enough. We tend to start with professionals and healthcare providers, and we want to just get more data. So we want to order more functional capacity evaluations, we want to get a second opinion, we want to send them here or send them there. And in a lot of those cases, you know, no one's really ever asked the worker why they don't want to return to work. So I think that putting the worker in the driver's seat, you know, not on all claims, but in ones where it looks like there's some problems, that would be really, is a really good thing to do. And we certainly have worked with some insurance claims managers, for example, in trying to encourage them to do that. So don't be afraid to ask the worker for what they think is the problem, because that could be really, really useful information to help solve problems versus going to always relying on healthcare providers.
Great. Let's see. In one of your slides, you talk about 7 factors affecting return to work. One of the factors is poor expectations of return to work or negative outlook of the future. Are there tools available to help workers achieve a better outlook?
Well, there are tools to measure this kind of thing for sure. There's been some efforts to develop return to work self-efficacy questionnaires and things like that that help us measure it. I think this the way you try to deal with it is through I guess what I would, as a psychologist, I would say are cognitive behavioral strategies. So having people understand that maybe they will be able to overcome hurdles that they face. And I think this problem-solving skills training is probably, you know, short of more psychological therapy techniques. This problem-solving skills training is really what would be best for dealing with this. So trying to encourage people to see that, okay, you can identify your problems, we can brainstorm possible solutions, we can think it through, and you have the skills to and the competence to do that. So trying to build a sense in workers that you have some control of this situation, you have the ability to contribute to this process. I think that's the key thing. So I think if people feel disenfranchised or that they're just a cog in the wheel of this huge administrative system, that's where this kind of factor is a real problem.
All right, very good. I think that's all the questions we have at the moment. So I think we might go ahead and end the webinar. I do have a few announcements, but first I just want to say thank you, Bill, for the presentation and for your work in this area. It's really interesting and also really beneficial as well.
Well, thank you very much. It was my pleasure.
Wonderful.
And thank you for the great questions as well.